My ears that there may be empty seats in the front. So come on up. So listen, so first of all, a couple of disclaimers. We are broadcasting, it's live, so please use microphones to ask questions. And since you're live and are going to be streamed on YouTube, be careful about what you say and watch your language. That goes especially for me. Okay, this is worldwide via Vimeo and YouTube. The recording is always available for viewing. Usually takes about 24, 48 hours, and it becomes live. Please like, comment, subscribe, and share your YouTube channel. And for our viewers, if you'd like to submit a question, text DeBakey to 37607. Introduce speaker. Excellent idea. Okay. So Jennifer was really kind enough to print this up in the smallest font that's available. So we're always playing gags on one another. But fortunately, I'm introducing a longtime friend, a guy who is truly a luminary in interventional cardiology, someone who, though much younger than I am, every time I look in any of our publications, he's always led a really important trial, not just a participant, not just a co-author, but a leader, who really is a leader in modern interventional cardiology. So, Jennifer, the bad news for you is I don't really need this. So Dr. Nicolas van Mieghem really is honoring us with his presence today. He trained originally in Belgium, then further training in the US at Lenox Hill, then back to Europe. He is now a full professor of cardiology at Erasmus University in Rotterdam, which really is where most European interventional cardiology studies are led, and that's where most thinking about interventional cardiology emanates from. So without further ado, Nicolas, teach us about TAVR. Yasser, you cannot sit in the back.
Good morning, ladies and gentlemen. First of all, I would like to thank Neil for the kind introduction, and I would also like to thank everybody here for the hospitality and the honor for me to be here. Thank you very much. So what I will do in the next 45 minutes or so, I will talk about the treatment of moderate aortic valve stenosis in the post-TAVR UNLOAD era. And for those of you who may have attended TCT, the TAVR UNLOAD was the first randomized controlled trial of treating moderate aortic stenosis. So these are my disclosures. And we're all familiar with the concept that Dr. Braunwald introduced in the late 60s. It takes time for aortic stenosis to mature and develop, degenerate, to become severe. And once it's severe, it also takes time before symptoms occur. But once symptoms are there, then there is an urgency to treat these patients. And the guidelines are very clear about that. So let's briefly touch upon disease progression. Once you have a patient with moderate to severe aortic stenosis, there is a progression rate per year that can be anticipated as follows. You can monitor the maximum velocities, the mean gradient, or the valve area. And if I just focus on the valve area, you can expect about a decrease in valve area of 0.1 centimeter square. So that is just a ballpark estimate, but it might become interesting when we are discussing the TAVR UNLOAD trial later on. So there is accelerated progression in patients who have more severe aortic stenosis. So the more severe the aortic stenosis is, the faster it will deteriorate. Also, the more calcium there is in the valve, that is a phenotype that will also see accelerated progression. And we see the same thing in patients, in men, and also in Caucasians. Why in Caucasians? Because there is more bicuspid aortic valve disease in Caucasians. What are the diagnostic tools? And I think the baseline is echocardiography. Echocardiography, however, has its limitations because we are measuring Doppler velocities. We are also measuring dimensions to determine the valve areas. And that is where sometimes it becomes difficult in terms of propositioning, so that you're not aligned with the flow and that you will underestimate the Doppler velocities, but also the way that your cutting plane might be different or might be off target, so that you will underestimate or overestimate the dimensions. At the same time, we have CT scanning, and in the CT scanning we typically focus on the amount of calcium in the aortic valve, and there are some cutoffs. So we know that when the Agatston score is more than 2,000 in men or more than 1,200 in women, that identifies or corresponds to severe aortic stenosis. Obviously, there are also discordant measurements by echo. So you measure a valve area less than 1 centimeter square, which corresponds to severe aortic stenosis, but you at the same time measure a velocity between 3 and 4 meters per second, or a mean gradient between 20 and 40 millimeters of mercury. That would be a discordant measurement. And then the question is this now severe aortic stenosis? Do we trust the valve area? Or is it moderate aortic stenosis, and do we trust the gradients or the velocities? So this is where dobutamine stress echo comes in, and it might reconcile the issue here. But there is also another end of the spectrum. If we are talking about moderate aortic stenosis, there is also there can be a discordance between the valve area, that is between 1 and 1.5 centimeters square, and a gradient that you measure to be less than 20 millimeters of mercury. Also there, the discordance can be resolved by using dobutamine stress echo, and this concept was also applied in the TAVR UNLOAD randomized controlled study. And it is basically summarized by Philippe Barrault in this slide. So if it's concordant grading, so the valve area that you measure is concordant with the gradients, then there is no issue. This is moderate aortic stenosis. The issue arises when there is a discordance between the valve area and the gradients that you measure. So it can be it can be mild or moderate, or it can be moderate or severe. That is where the dobutamine stress echo will come in. Sometimes it still is inconclusive, and then an integrated approach, including CT and an evaluation of the Agatston score, becomes relevant. That said, the Agatston score cannot replace dobutamine stress echo. And this is a recent publication that we did together with Steve Little. We identified 214 patients with a valve area of less than 1 centimeter square, but a mean gradient less than 40 and maximum velocities less than 4 meters per second. So exactly a discordant measurement. Those patients went on to receive a dobutamine stress echo, but also a calcium scoring by CT scanning. And we wanted to know what the correlation would be between the Agatston score and the result of the dobutamine stress echo. So if the dobutamine stress echo would conclude severe aortic stenosis, well, would we then find Agatston scores more than 2,000 in men and more than 1,200 in women? Turns out that this correlation was not so good. So the area under the curve for men was less than 51. For women, it was less than 55. Basically, it was almost tossing a coin. So that tells you that an Agatston score cannot replace dobutamine stress echo in the evaluation of patients with discordant aortic stenosis. And here are some examples. You have here modest or mild and lower Agatston scores by CT scanning, but at the same time, the result of the dobutamine stress echo was severe. And you also have the other extreme with a lot of calcium on the CT scanning, but a dobutamine stress echo that concludes moderate aortic stenosis. The interesting part of that study is that we also looked at the patients, what happened to those patients later on. Turns out that 60% of the patients with so-called moderate aortic stenosis, so pseudo-severe and therefore moderate aortic stenosis, went on to receive a TAVR valve within the first year. So keep that in mind when we are discussing the TAVR UNLOAD trial. So what is the issue with moderate aortic stenosis? And we have two vast registries, echocardiography registries, that looked into the outcome of patients with moderate aortic stenosis. One from Australia and one from the United States. And this is the Australian data set. More than 240,000 echoes were evaluated. The median follow-up of the patients was more than 1,200 days. The majority of the patients obviously had no aortic stenosis. But then if you look at the patients who developed aortic stenosis, as patients are aging, you will see more severe aortic stenosis. So the mean age of the patients with severe aortic stenosis was 78, with moderate aortic stenosis was 74, and with mild aortic stenosis was 72. Of interest maybe is that there were more patients with severe aortic stenosis than with moderate aortic stenosis. Probably that has to do with referral patterns, with the way we identify moderate and severe aortic stenosis. But this was obviously self-reporting, side reporting. So bear that in mind. If you look then at the outcome of those patients, it turns out that at 5 years, but also at 1 year, the outcome of the patients with moderate aortic stenosis was not so different from the patients with severe aortic stenosis. And this basically was duplicated in the United States. The data set was even more robust, more than 500,000 patients with echo studies. Again, the majority of patients had no aortic stenosis. 70,000, more than 70,000 patients had any kind of aortic stenosis. And if you then look at the outcome, you see clearly much more hospitalizations in the patients with severe aortic stenosis. But look what's happening to the patients with moderate to severe aortic stenosis. It clearly separates from the patients with moderate and mild aortic stenosis in terms of hospitalizations. And if you look at mortality, then you see that the patients with the mortality of the patients with moderate to severe aortic stenosis creeps into the direction of the patients with severe aortic stenosis. So there's clear overlap here. And definitely the patients with moderate aortic stenosis had a worse survival than the patients with mild or no aortic stenosis. So there is something going on with aortic stenosis, and indeed this is a meta-analysis that tried to come with a benchmark. Patients with moderate aortic stenosis, they have a risk to die within the first year. They also obviously have a risk to, something is happening here, but I can still see the slide over there. There will be a risk for aortic valve replacement, as you would expect, because the valve will degenerate further over time. So there is I can no longer move my slides. And here I don't see the slides anymore. There's no more.
Yeah, it's not linking.
Well, the good thing is I can do it without slides if need. Done it before. Yeah, we're there again. Thank you very much. So, in that same meta-analysis, they also dragged in a group of patients with severe aortic stenosis and no or mild aortic stenosis. And then they looked at what are the hazard ratios of moderate aortic stenosis. Well, clearly it is higher. You will have more events as compared to mild aortic stenosis, but not so many as severe aortic stenosis. So definitely, make no mistake, moderate aortic stenosis is not the same as severe aortic stenosis. Now, what about the interaction of ejection fraction? What about moderate aortic stenosis in the context of LV dysfunction? That same meta-analysis looked at the outcome of the patients with or without depressed LV function. Turns out that the outcome at 1 year was 4 times higher in the patients with depressed LV function, with an ejection fraction less than 50%, as compared to the patients with an ejection fraction more than 50%. And this was also echoed in the data set by Jeroen Baks in Leiden, where he identified almost 2,000 patients with moderate aortic stenosis. 1 in 5 of those patients had a depressed LV function, and clearly they were doing much worse than the patients with moderate aortic stenosis and preserved ejection fraction. And this also is nicely demonstrated in this illustration, where you see that as the ejection fraction goes down, the hazard ratio goes up. We also looked at the number of outcomes, the number of events in patients with moderate aortic stenosis and so-called HFrEF, so heart failure with reduced ejection fraction, and it was quite significant. 310 patients from Leiden, Rotterdam, Columbia University, and Quebec, and it's clear that the event rate is high, and if you do the landmark analyses, each year the event rate remains high. So basically you have the first year, but then after the first year, ongoing high event rates, and once the ejection fraction is below 50%, there was no significant difference between the patients with an ejection fraction less than 35% or higher than 35%. So we are building on a story, so we collaborated again with our colleagues from Quebec and now try to do a comparison of patients with HFrEF and no aortic stenosis, comparing them to patients with HFrEF and moderate aortic stenosis, and then try to look at the event rates. Clearly, the event rates were much higher, so moderate aortic stenosis amplified the risk of HFrEF patients. That was clear from this analysis, both in terms of mortality, but also in terms of mortality and heart failure hospitalizations. And this is a recent meta-analysis of patients with moderate aortic stenosis, comparing them to patients with no or mild aortic valve stenosis, irrespective of ejection fraction. If you look at the patient phenotype, obviously, as expected, patients with moderate aortic stenosis were on average older. They also had more ischemic coronary artery disease, and we are familiar with patients with aortic stenosis, up to 50% or more have concomitant coronary artery disease. And obviously, the measurements by echo were in keeping with moderate aortic stenosis in one group and not in the other. Well, if you do a raw comparison, and I think this is quite an important analysis, then you have the impression, just similar to what we saw in the Australian and the US data set, that patients with moderate aortic stenosis had a worse prognosis, had worse survival than patients with no or mild aortic stenosis. And this also was clear for patients with an ejection fraction less than 50%. But if you would do a matched comparison, so you would try to look at confounders, then all of a sudden the difference between no and moderate aortic stenosis in patients with normal ejection fractions becomes more subtle. Is there a difference? Well, not so clear for patients with preserved ejection fractions, but still clear in patients with moderate aortic stenosis. So this was all of interest and definitely was the driver in retrospect of the TAVR UNLOAD trial. Why would we want to focus first on the patients with HFrEF? Well, this was the reason. This was the reason. And what also is of interest, the hazard ratio in patients with preserved ejection fraction is slower, goes up slower, but is very steep. So very early events, you can expect very early difference in event rates in the HFrEF patients with moderate aortic stenosis. So there are different phenotypes of moderate aortic stenosis, and this is the concept of cardiac damage as introduced by Philippe Généreux. You have a grading, stage 0 to 4, and it starts with, is there something changing in the LV? That is stage 1. If it then starts to transition to the mitral valve and the left atrium, you enter stage 2. If it enters into the pulmonary circulation, it becomes stage 3, and if the RV is affected, it's stage 4. And as you are transitioning from stage 0 to stage 4, the event rate will increase dramatically. That is the concept of cardiac damage that is introduced or that has been applied in 2 other randomized controlled trials of patients with moderate aortic stenosis, and we'll get to that later in the presentation. Jeroen Baks from Leiden has been very involved in the moderate aortic stenosis research. He again used his vast data set of patients with moderate aortic stenosis to look at discordant or concordant moderate aortic stenosis. And concordant moderate aortic stenosis, again, patients with a valve area between 1 and 1.5 centimeters square in combination with a mean gradient between 20 and 40 millimeters of mercury. Discordant when the valve area and the gradients are basically different. and not in keeping with moderate aortic stenosis. But this group is fundamentally different than the concordance. Obviously, the majority of patients, 60% had concordant moderate aortic stenosis, 40% had discordance. And if you look at the discordance, you can have a low flow situation or a normal flow. And the normal flow can be paradoxical, normal flow with a low gradient, or you can have a paradoxical low flow with a low gradient. Those patients have a preserved ejection fraction, but still have a low stroke volume. Well, that basically also transitions or translates into more events. Patients with a low flow phenotype are the patients that will do worse. So both the patients with a classical low flow, low gradient and patients with a paradoxical low flow, low gradient, moderate aortic stenosis, those are the patients with the worst prognosis. And then if we only look at patients with a preserved ejection fraction, again, the patients with a discordant moderate aortic stenosis have the worst prognosis. So this is maybe a way of trying to get to the sweet spot of which patients might benefit most of a treatment of moderate aortic stenosis. But from the data of Leiden, it's clear that a low gradient moderate aortic stenosis is the worst phenotype. Now that brings me to the concept of upstream management. Current guidelines say, well, you have to wait for the aortic stenosis to become severe, and once it's severe, you wait for symptoms to occur, and then you intervene. But why would we wait for all this to happen? Is there a rationale to do this treatment earlier? Why? Because in this process of deterioration and degeneration, things are happening in the muscle of the heart itself. So the myocardium is changing, and you will start to see fibrosis. The issue is that at one point, there is this situation of maladaptive fibrosis that is also not reversible anymore. So if you enter that stage and you replace the valve with a patient with maladaptive fibrosis, well, the fibrosis will remain and the patient will remain at risk for events such as sudden death and heart failure. A ventricle that is exposed to aortic stenosis will have a pressure overload in the beginning, but if we wait long enough, the pressure overload will transition to a volume overload. Obviously, once volume overload is there in combination with aortic stenosis, that is the worst phenotype, and that is the patient that will have the highest event rates. So then the question is moderate aortic stenosis a new target? Philippe Barrault has been an advocate for the valvulo-arterial impedance, and this is basically the global burden on the ventricle, the loading burden of the ventricle. And it consists of the valvular component, aortic stenosis, but also the arterial component, hypertension, for instance. What was interesting, in the patients with high valvular arterial impedance, the majority was, as expected, based on severe aortic stenosis, but 1 in 4 had moderate aortic stenosis. And still, those patients were the patients with the worst prognosis. So if you only have medical therapy for patients with high valvular arterial impedance, those patients are the patients with the worst prognosis. So the question there is, what would happen if we treat the moderate aortic stenosis? Can we then resolve the afterload? Can we reduce the afterload further? Because at one point, the arterial load will no longer be affected by medical therapy. There is no more response to vasodilating the arterial system. And then the question is, okay, if we target the moderate aortic stenosis, can that be a target to further reduce the afterload? And obviously the basis of heart failure therapy in the context of a reduced ejection fraction is afterload reduction. So is this complementary to medical therapy to replace the valve? That is the question. We did look into the literature, and we were also part of this comparative study. Again, we did a propensity scoring, a propensity matched analysis, where we looked at the Atlas-TAVI registry. This is a registry on patients with low flow, low gradient AS. Patients had dobutamine stress echo, and so you had a subset of patients with pseudo-severe, therefore moderate aortic stenosis, who received a TAVR valve. Now we one-to-one matched them to patients with moderate aortic stenosis in our practices. Turns out that the patients who were treated by TAVR, those patients had the best survival and had fewer heart failure hospitalizations. So this, again, was an indirect link to potential benefits of TAVI or TAVR for moderate aortic stenosis. Now, I think a strong scientific basis for a randomized controlled trial. And in 2013, when I was doing my labs in the swimming pool, I came with the idea of the TAVR UNLOAD randomized controlled study. All the data that I just showed you was not available at that point, but somehow I was intrigued by moderate aortic stenosis and this concept of afterload reduction for heart failure patients. And that was the rationale to design the TAVR UNLOAD. The TAVR UNLOAD is a randomized controlled study looking for patients with symptomatic heart failure, so they had to be in New York Heart Class 2 or higher, and they had to have guideline-directed medical therapy in combination with moderate aortic stenosis. The patients would be randomized to transfemoral TAVR with a balloon expandable valve or clinical surveillance. Clinical surveillance with the plan to treat the aortic valve once it was documented that moderate aortic stenosis had transgressed to severe aortic stenosis. Now, the original idea of the study, we'll get to that later, was to identify 600 patients and then one-to-one randomize them to TAVR or clinical surveillance. Unfortunately, we ended up with 178 patients, 89 patients in each treatment arm. The primary endpoint was the hierarchical occurrence of all-cause death, stroke, hospitalizations for heart failure or aortic valve disease-related issues, or a change, an improvement in quality of life as assessed by the KCCQ. The evaluation was done using a Finkelstein-Schoenfeld method and was presented as a win ratio. We'll get to that later. As mentioned, the original design was 600 patients and a follow-up and an endpoint analysis at 1 year. Unfortunately, we had relatively slow enrollment at the get-go. We also had the issue of the COVID pandemic, so we were forced to redesign the trial. So we decided to change the follow-up at 1 year to longest available follow-up. Why? We would increase the event rate, more events. So that would also allow us to reduce the sample size to 300, 150 in each treatment strategy. Unfortunately, there were funding constraints. The slow enrollment continued because of COVID, and so we were forced to end the study on December 31st, 2022. Now, the inclusion criteria for the trial, again, as mentioned, symptomatic heart failure, guideline-directed medical therapy, proven moderate aortic stenosis, also confirmed by the core lab prior to randomization, ejection fraction at rest less than 50%, and the patient had to be suitable, had to have a suitable anatomy for a transfemoral TAVR. These are the baseline characteristics. Patients were in their late 70s, 1 in 5 were women, and the STS score was 4.4. So we're talking about an intermediate operative risk phenotype. At the same time, the patients had also advanced heart failure because the majority of the patients were in New York Heart Class 3 or ambulatory Class 4. Also, almost 50% of the patients had had a heart failure hospitalization in the year prior to study enrollment. So advanced heart failure, also demonstrated by the left ventricular end diastolic diameter of 6.6 centimeters, which is these are patients with dilated ventricles. At the same time, we had moderate aortic stenosis. So look at the valve area, 1.2, a mean gradient of 22 millimeters of mercury, and approximately 50% of the patients had a dobutamine stress echo to resolve and reconcile discordant aortic stenosis. I think it's good, before we go to the endpoints, to look at what happened to the patients who received TAVR in the treatment arm. So was TAVR safe? Well, look at the safety endpoints at 30 days. At 30 days, so no mortality. There was 1 stroke, and the pacemaker rate was less than 5%. Basically what you expect in contemporary TAVR practices. What happened to the patients in the clinical surveillance arm? And obviously, we would be interested in the progression to severe aortic stenosis because those patients were not being treated for their aortic stenosis at that point. Turns out that 39% of the patients in the clinical surveillance arm progressed from moderate to severe aortic stenosis, and almost 20%, 16 patients, the first year. And then in the subsequent years, more patients were progressing from moderate to severe aortic stenosis. And the point is that those patients all of a sudden had a class 1 indication for aortic valve replacement. So they all were treated with a TAVR. Half of those patients had an adjudicated heart failure event. If you look at all the patients in the control arm and the clinical surveillance arm who received a TAVR valve, then you end up with 43% of the patients. So all the patients who progressed to severe, but also a couple of patients who had proven and confirmed moderate aortic stenosis went on to get a TAVR procedure because they had recurrent heart failure events. This is an interesting comparison. This is a competing risk analysis in the clinical surveillance arm. So on the left-hand side, you see the proportion of patients who received a TAVR. And you see over time, more and more patients were being treated with a TAVR because their moderate aortic stenosis progressed to severe. On the right-hand side, you see the proportion of patients who died without receiving a TAVR. And also there, over time, you see the number is growing. So at 3 years, all the patients in the clinical surveillance arm either had a TAVR or had died. So there were no more patients who were not treated and were still alive in the clinical surveillance arm. And this is quite a remarkable observation. So you see that the number of patients who are alive without TAVR is fading out, is fading away. So let's go to the primary endpoint. And this is the hierarchical endpoint, and the analysis is done using the Finkelstein-Schoenfeld method. I'm not a statistician, so they had to explain to me why we would do this and how it works. Basically, how it works is that you take every patient in the TAVR arm and you compare that one patient to all the patients in the control arm. And then you want to see who's winning. And you first start at who's winning in terms of mortality, and then you continue with who's winning if the patient, so for instance, patient A and patient B in the control arm, patient A survives, patient B dies, that's a win for TAVR. But patient C died in the TAVR arm and patient D survived in the control arm, then that's a win for the clinical surveillance group. But there are also patients who are alive in both groups, that's a tie. All the ties will then go on to the second level, so only in the tied group you will start to look for stroke. And you do the same thing, who is winning in terms of stroke, who is winning, is there a tie? If there is a tie, you go to the hospitalization. And so you gradually work yourself through the hierarchical endpoint. So there was no difference in mortality between the two treatment strategies. So you had 22% of wins with TAVR, 22% of wins in the clinical surveillance arm, 56% ties. Those 56%, they went on to the analysis, to the comparison for disabling stroke. No difference in terms of stroke. Then we go to hospitalizations. That was a surprise to me. We did not see a difference, a significant difference in wins between the two treatment strategies at longest follow-up. Then we went on to KCCQ, so the improvement in quality of life. And also there, we had numerically more wins with TAVR. But at the end of the day, if we look at the aggregate, the win ratio was 1.3 in favor of TAVR, but it did not reach statistical significance at longest follow-up. And remember, we started, our initial goal was to do the analysis at 1 year, but we had to modify. Well, if we would have used the original endpoint at 1 year, then we see a win ratio of 1.55 in favor of TAVR, and that was statistically significant. But obviously, we were no longer powered for that endpoint. Looking at the major events, the Kaplan-Meier's of MACE and all-cause death were superimposed. So there was no difference in hard clinical endpoints between the two treatment strategies, and that is also clear from this slide. So here are the numbers. All-cause death was 9% at 1 year in the TAVR arm, 13% in the clinical surveillance, numerically there were more strokes, and this is of interest because we saw something similar in the early TAVR trial. So preemptive TAVR seemed to have less strokes numerically than clinical surveillance. And if you look at the heart failure hospitalizations, numerically maybe less in the TAVR arm, but overall no difference. Let's look into these hospitalizations, because we're looking at hospitalizations for heart failure or a valve-related event or an equivalent. And an equivalent is if a patient would come to the emergency room, diuretics are adjusted, that would also be counted as an event. Well, hospitalizations for heart failure seem to be higher in the clinical surveillance arm. Urgent heart failure outpatient visits to adjust diuretics and so on, again, seems to be more in the clinical surveillance arm. But look at this, and this was a surprise to me. Why would we see more hospitalizations due to aortic valve disease in the TAVR arm? Are there issues once we have replaced the valve by TAVR? Turned out that this had to do with definitions. And the definition of a heart failure event for the TAVR patients was that if the patient would receive a TAVR at the index hospitalization and the hospitalization would exceed 5 days, that would be counted as an event. I had a little bit of an issue with that criterion, but then obviously you see that there were 7 of those in the TAVR arm and 0 in the clinical surveillance arm. As a matter of fact, the patients in the clinical surveillance group who received the TAVR never had a hospital stay of longer than 5 days. And there were 7 of those cases in the TAVR arm. This is a little bit of a play of chance, so we did an additional analysis excluding those patients. Still, our endpoint, the primary analysis, would have been no different. So let's go to the quality of life then. As expected, if we do a TAVR, we see an immediate and steep increase in the quality of life of those patients. So there was an increase in the KCCQ of a mean of 12 points, which is considered to be large. In the clinical surveillance arm, you see this humpy, bumpy road, but over time you see that the difference between the clinical surveillance and the TAVR arm is declining. Why? Obviously because the patients were progressing from moderate to severe and were treated with TAVR. So if we now look at the clinical surveillance arm and we censor the patients who receive TAVR, then it becomes clear what TAVR does to you. You improve your KCCQ, your quality of life. In these patients with moderate aortic stenosis and HFrEF who did not get a TAVR, nothing happened in their quality of life. So basically, this is one of the conclusions. If you treat HFrEF patients with moderate aortic stenosis with a TAVR, you will affect their quality of life, but you will not affect the hard clinical endpoints. There are some limitations to the study. The study was underpowered due to slow enrollment and insufficient sample size, and the findings are therefore hypothesis generating. At the same time, we faced this slow enrollment, and that was obviously a big frustration to me as a primary principal investigator. Why was that? Well, back in the day when we started to enroll patients, there was an inertia in referring hospitals to send patients with moderate aortic stenosis because that is not our practice. We are not trained as cardiologists to refer patients with moderate aortic stenosis for valve replacement. So it took some time to convince the community to get these referrals. That was one. Then we had obviously the COVID pandemic. And then the third one is the PROGRESS trial. So we had funding for the TAVR UNLOAD by a grant from Edwards. But Edwards also was developing a industry-sponsored trial that was focusing on cardiac damage, the concept of cardiac damage. But all the patients of TAVR UNLOAD would qualify for PROGRESS. So there was a conflict there, and at one point, you had the investigator-initiated trial and an industry-sponsored trial. Do I say more? The multiple study design changes affected the study results, and I mentioned to you the timing of the primary analysis by changing it from 1 year to the longest available follow-up. Obviously, that skewed the interpretation. And we were surprised by the progression of moderate aortic stenosis. There were much more patients progressing earlier in the clinical surveillance arm. That was really unexpected. And also we have to bear in mind that this trial started in 2017. At that time, guideline-directed medical therapy for heart failure was different from now. Now we have Entresto, we have the SGLT2 inhibitors. Those were underused in the TAVR UNLOAD trial. TAVR UNLOAD is not the only trial, so we now have that data. The PROGRESS trial has completed its enrollment, and we expect the first results 2 years from now, so in 2026. And then there is one more trial, and I think you are also part of that study. Obviously, you are one of the leaders in the EXPAND TAVR 2 randomized controlled study, and also that trial is incorporating the cardiac damage concept. So this is, I would say that TAVR UNLOAD is a heart failure trial, whereas PROGRESS and TAVR EXPAND 2 are aortic stenosis trials, pure aortic stenosis trials. So with that in mind, we also looked into our own experience in Erasmus beyond TAVR UNLOAD. And we did this retrospective analysis because we were thinking, well, the sweet spot of moderate aortic stenosis, of the treatment of moderate stenosis, would be the HFrEF patients, the patients with depressed LV functions. Maybe that's not the case. So we looked at patients in between 2015 and 2020, and we identified 115 patients who were treated for moderate aortic stenosis. But at the time of treatment, they were considered by the heart team as having severe aortic stenosis. By reviewing the echoes by cardiologist core lab, it turned out that the conclusion was, yeah, but these patients actually had moderate aortic stenosis. Well, we looked at those patients and compared them to 220 patients with moderate aortic stenosis who went in the clinical surveillance program. And those patients had moderate aortic stenosis, were above 50 years, and we would exclude the patients with low gradient AS, so no discordant aortic stenosis in those patients. These are the baseline characteristics. If you look at cardiac damage, there was cardiac damage in the TAVI cohort, much more common than in the clinical surveillance cohort, and the ejection fraction was somewhat lower, but still 72% of all the patients in this study, in this retrospective analysis, had preserved ejection fractions. Again, we see here that TAVI patients did better than the clinical surveillance patients. This is basically an echo of all the data that we saw running into the TAVR UNLOAD, the retrospective analyses, but there is selection bias, but the patients who received TAVR seem to do better than the patients in the clinical surveillance arm. What were the predictors of survival in our registry? Well, TAVI was probably a strong predictor for survival. So I don't believe that that TAVR UNLOAD is the end of the story. The story is only beginning, obviously, and I do feel that we will need more randomized studies, and I'm very much looking forward to the PROGRESS and TAVR EXPAND 2 results. So in conclusion, I hope you agree with me that moderate aortic stenosis is not a trivial thing, and it has clinical impact. All imaging modalities to determine aortic stenosis, they have their limitations, and I think a more integrated approach is the way to go. The pathophysiological concepts, they may support upstream aortic stenosis, treatment of moderate aortic stenosis, but we need the scientific background. In TAVR UNLOAD, TAVR for moderate aortic stenosis in patients with HFrEF on guideline-directed medical therapy was safe, but it did not affect the primary endpoint at longest follow-up with a median of 23 months. That said, within the first year, we do see clinically meaningful improvements in quality of life with TAVR as compared to clinical surveillance. But then again, a significant number of patients who are in the clinical surveillance program, they will progress to severe aortic stenosis, and they will need, or they will have a guideline-directed therapy or indication for valve replacement. So is TAVR UNLOAD a trial that will change the guidelines? No, I think the guidelines are quite solid, and it is safe to follow the guidelines for now in patients with HFrEF and moderate aortic stenosis, because there is no penalty for mortality, there is no penalty for stroke, and there also seems no penalty for more heart failure hospitalizations. The cardiac damage framework is intriguing and may identify another patient phenotype where we can maybe or maybe not identify significant benefits with TAVR, but that is why we have to await progress and expand TAVR to trial results. Thank you for your attention.
Well, wow. I think that was an absolutely fantastic presentation. You know, sitting here making a list of questions to ask you, and so far it's topped 1,000. But that would be unfair to the audience. So let me, again, let me start by congratulating you on doing a very difficult trial. And, as we discussed, the most important trials in medicine are usually the toughest to do. So once again, congratulations. So one question out of many. When I think of patients with HFrEF, AS, moderate AS, and heart failure, I think of struggling to get that transvalvular gradient as low as possible, just to mimic what our heart failure colleagues do when they unload a patient medically. Do you have any data on gradients and outcomes here?
So we are working on an in-depth analysis. So there's a sub-study coming on the echo and the changes in echo. What I can tell you is that we started with a valve area of 1.2. We got the valve area to 1.8 in the TAVR arm. And the mean gradient started at 22 and we got it down to 12. But we did not look into the nitty-gritty details of the patients with low flow, low gradient, the patients who required a dobutamine stress echo. But this definitely is an important analysis. Unfortunately, the numbers, the sample size is relatively small because we had to interrupt the study. And I think you need enough patients to do these specific analyses. So, yeah. But there is also already a plan to use the patients from progress with HFrEF and amplify and enrich the TAVR UNLOAD patient population. So you can expect that in parallel with the presentation of progress, we will come up with a patient-level pooled analysis that's already in the making, and that will give us, hopefully, a sample size for further analyses.
Are you able to add expand to that?
But I'm afraid that expand will take some more time to complete its enrollment, and obviously then you will introduce a different platform, and that is also intriguing because we are familiar with the gradients after a balloon expandable valve being higher than with a self-expanding valve. And if we are talking about afterload reduction, what would be the most attractive? Maybe the valve platform with the best hemodynamic valve performance.
Thank you very much, really. It was a superb presentation. It was great to have you. Appreciate that. I think you've done amazing contributions to the field, and we want to really congratulate you with this. And I'm glad you thought about it while you were swimming. Obviously, you had a lot of challenges that you've enunciated. The other challenge I see is that you're competing with yourself almost at the same time, meaning patients are maturing, accelerating into aortic stenosis, and they will have an indication for a TAVR at the same time. So if I want to think about it in this population, which conceivably makes sense to decrease, afterload on this ventricle, and a ventricle that is really failing, and you would think that will be some improvement. So I was thinking of what are the major things that we would think about in this situation. One is sudden death and bad heart failure, because these are patients with bad heart failure. And so in that population, many of them have ICDs. I know it's a small number, but did you decrease the number of ICD shocks in some of these patients that could be contributing to your lesser, delta between the two? And that's my concern. And the question is, are you going to proceed further and do this because I think it's really worthwhile, and you had a lot of challenges to be able to continue that.
Thank you very much for the comments. Patients who who received an ICD shock, they were counted as a heart failure hospitalization or equivalent. So that was taken into consideration. I don't know, we didn't identify the exact number, so that I cannot say. But this is definitely worthwhile to look at the number of shocks that we've seen, but it was not that high, to be honest. To comment also on that is that, listen, by replacing the valve and by treating moderate aortic stenosis, we are not solving heart failure, right? So and the majority of the patients had an ischemic cardiomyopathy. We didn't change that. So the improvements of ejection fraction was marginal, was really marginal. So again, what struck me was the speed of progression of moderate to severe aortic stenosis in the control arm and the clinical surveillance arm. And one of the takeaways for me is that my practice up to seeing the results was to bring patients with moderate aortic stenosis back for another echo 1 year down the road. I think we have to be more meticulous. They need to come back earlier for an echo assessment. What we do now is we would bring the patients back after 4 months or after 6 months, but we would not necessarily do the echo. And that has to change because there's so many patients that are progressing very fast. And then you can really help these patients by treating them because you would probably keep them out of the hospital.
Nicholas, thank you very much again. Terrific presentation and congratulations on the trial. Alongside Dr. Kleiman's question, I'm always interested in the stroke volume. We look at the ejection fraction, we look at the valve area, the gradient, but the stroke volume ultimately is, what the ultimate, the output of the heart, if you will. And do you have any data looking at stroke volume or, outcomes stratified by stroke volume? When you talk to someone like Amar Abbas, for example, he says that, the low gradient, versus high gradient debate has been going on for a long time. And he presented some data showing that patients who have low gradient actually have lower stroke volume. And that may not necessarily be a good thing, which, we all have, our own thoughts. But I'm just curious to hear your thoughts about the stroke volume concept.
I'm very intrigued by the low flow, low gradient AS. And we have a bunch of those patients. So 50% approximately of the patients in TAVR UNLOAD had a low flow, low gradient. What is happening with the flow after the valve is replaced? There is not very consistent data that shows that the flow is improving after the valve has been replaced. So that is definitely something to look out for in the analyses that we are about to do and that we hopefully will be presenting around the ACC time window.
Thank you for the amazing talk. I also attended your initial presentation at ECT. I have 2 questions. Since you mentioned that it's more of a heart failure trial than the aortic stenosis trial, if we can have like a pre-TAVR hemodynamic data to make sure these patients were well optimized, also have some data on the pulmonary hypertension and the RV dysfunction, if this study or the prior study, if you came across. And my second question is, do we have any outcomes based on the etiology of heart failure, hence like ischemic versus non-ischemic, since both of these group of patients behave differently and they have different outcomes? Thank you.
So very relevant questions, but the right heart caths were not mandatory in the trial. So that was not documented, not collected. But it makes sense to revisit this and to try post hoc to collect these data and see whether we can find any issues there. Your second question was?
Ischemic versus...
Oh yeah, ischemic versus non-ischemic. We know that ischemic cardiomyopathy is a different phenotype than non-ischemic cardiomyopathies. Unfortunately, only 1 in 4 of the patients in TAVR UNLOAD are non-ischemic. So we're talking about 2 small sample sizes. Yeah.
Nicolas, thank you again for a wonderful presentation, and thanks for coming down. It was great to see you at TCT. One is the exciting topic of myocardial fibrosis on MRI, I guess. I'm really curious to know your thoughts on that. I think It's very evolving, and obviously the damage framework and so on and so forth. But I'm really curious to see what your thoughts are, where that field is going to go, because we continue to struggle, whether it's severe or especially moderate, in trying to identify patients, irrespective of their LVF, whether to send them for SAV or TAV or whatever it may be. So I'm curious if that is going to be a concept of reality for future. Second, kind of a little bit talk about, so in your TAVR UNLOAD, I did not see much of coronary revascularization at all. And I know you alluded a little bit to that, but in today's day and age, if somebody has moderate AS and if there's multivessel CAD or a proximal CAD, it is almost a given that that patient is going to go historically for SAVR and CABG. Is there any point of looking at such moderate AS patients who have concomitant severe CAD? And is that something which would be interesting to compare those two groups with TAVR?
It's definitely interesting, but I can tell you that for the purpose of the trial, significant coronary artery disease had to be addressed prior to study entry. So the patients had to be revascularized before they became eligible for the study. And the interval between the revascularization and eligibility for the study was 3 months. So no interventions, and no, basically we wanted to solve the issue of coronary disease prior to study entry, but that doesn't mean that you solve the issue of ischemic cardiomyopathy, right? I think the patients that we would typically send to surgery with complex coronary artery disease and moderate aortic stenosis, that's a different group of patients, and there is already, I mean, our surgeons are already treating those patients and replacing the valve concomitantly. There is also a guideline to support that. I think that is a different question.
No, but what I'm trying to say is that is the needle going to move where, with success of doing TAVRs and moderate AS, that instead of sending those patients for bypass surgery and SAVR, is it possible to see a day where you can do a TAVR and multivessel PCI?
Difficult one.
Because, you know, like you eloquently showed so much data about association of moderate AS and mortality, cardiac mortality. It was very beautiful. And most people do not know that moderate AS is associated with that. The question is it an association, observation, or is it actually the causality? And I have to wonder if it is other disease, such as severe proximal coronary artery disease, multivessel CAD, could also be a contributing factor, not just LVF.
Well, my short answer would be that it seems to be associated with it, but it's not the causality. So the moderate aortic stenosis is not the cause.
Remember that these are both really systemic illnesses.
Yeah.
Except for bicuspids.
Yeah. So, yeah. Back to your question on the MRI. You can't help but looking at the EVOLVE trial that also was presented and published in JAMA simultaneously. That ended up also to become a negative study, which was a little bit disappointing because you were really looking at a higher risk phenotype based on what we know from the literature in terms of mid-wall fibrosis. And it was a surprise to me. At the same time, the way that the patients in EVOLVE were followed up and what happened in terms of planning of their treatment and so on was more realistic probably than what was presented in the early TAVR trial, where the speed of treatment of these patients was maybe not reproducible in everyday practice. Yeah.
Great presentation. Thank you so much for coming down. I had one question. Did you guys think or look at univentricular versus biventricular failure and how these treatments respond? Because RV failure can really murk up the picture.
So it's clear that you are very much involved with echocardiography, and there's a strong foundation with echocardiography, and I think it's a very good question. So you guys need to be involved in our echo paper from TAVR UNLOAD, because I think this is where the cardiac damage comes into play, right? Because you're talking about RV failure, that is advanced cardiac damage, stage 3 and 4.
Nicholas, I'm very upset. He is not an echocardiographer. He is a hardcore interventionalist, defender of the faith, and protector of dialysis.
But at the same time, he's a smart individual, and that's also good.
He's here.
Exactly. Very good.
Well, great.
All right, thank you very much.
Thank you. Oh, that's amazing.